I want to invite you all on behalf of the Mobile Data to Knowledge Center based at the University of Memphis. I'm Vivek Shetty, the director of the training core. And today we have Professor David Vetter, who is the Elma Schneider Chair at the University of Texas MD Anderson Center. Dr. Vetter is part of the MD2K's Thrust 2, focusing on smoking cessation. He is a very prominent researcher, translational researcher, working on smoking cessation behavioral interventions, has published very extensively, has been also supported extensively by NIH-funded research, and has won multiple awards, including awards from the Society of Behavioral Medicine, the American Society for Preventive Oncology, and the American Psychological Association. Professor Vetter, thank you for joining us, and I hand it over to you.
Well then, one correction, I'm actually at Rice University. I was at MD Anderson for 18 years though, so not a problem. For those of you that aren't behavioral scientists, this is going to be maybe a little bit different than what you're used to seeing, because it's really about behavioral science and the role of social determinants on influencing health risk behavior. But I'm hoping that that you'll actually be able to get a sense perhaps of how MD2K kind of plays into addressing some of these things as we go on. So let me just dive right into it. So first I'm going to tell you just a tiny bit about what our team does, because so you can see the context in which MD2K plays a role, then why we study tobacco and the social determinants of health. And then I'm going to talk to you a little bit about modeling pathways that link socioeconomic status to smoking cessation, because there's a voluminous, 100-year excuse me, blanking here, 100 years of research on the role of social determinants and socioeconomic status, but we still don't clearly understand the mechanisms that link some of the social determinants to health behaviors. And so I'm going to talk to you about a little bit of our work there. And then I'm going to talk to you about the role of macro and micro context on smoking cessation. And I want to really highlight that context, or the environment and environmental influences, are incredibly powerful in shaping behavior. And I think a lot of that is sort of getting lost in the excitement of genetics and genomics and precision medicine, and we're going to solve all the social ills in the world with the fact that we've mapped the human genome now. And in fact, context plays just as big a role, and I'll show you some of those effects and how big they are today, I think. And then finally, we'll take a minute just to sum up. So just to tell you a little bit about our team, we study health risk behaviors, primarily tobacco, but other health risk behaviors as well. And our goal is to eliminate inequities in those behaviors, meaning differences between population groups, whether it's based on socioeconomic status, race, ethnicity, gender, etc. We use an approach that we call the 3 T's, which refers to translational, transdisciplinary, team science. Translational means that in all our work, including our theoretical and conceptual modeling work, we're doing that with an eye towards translating it into interventions and using those interventions in real-world settings. Transdisciplinary, meaning we look at things from a wide variety of perspectives. We collaborate with sociologists, geneticists, geospatial scientists, as well as with a host of computer scientists, engineers, computational scientists. So that's what we mean by team science. We really bring in a wide variety of perspectives, because it's really necessary if you're going to try to cover as much ground as we would love to be able to cover. So we try to go all the way from what from NIH refers to as discovery to delivery, meaning we do the basic biobehavioral conceptual work, we develop interventions based on that work, and then we attempt to deliver them and disseminate them in real-world systems. So In terms of the methods we use, here's where we're using a lot of MD2K technology currently. We have 2 new R01s that are funded with collaboration, from Santosh at Memphis and Jim Ray from Georgia Tech and Emory Urton from Ohio State and folks from MD Anderson, my old place. So really with a lot of the MD2K investigators, and we're studying social determinants in both of those R01s. And we use a lot of the, so we're using AutoSense with the on-body sensors. We're taking a GPS reading every 5 seconds. We're using ecological momentary assessment. We're linking that to larger GIS measures of neighborhood characteristics as well as with genetics. So we take all those kinds of work and we develop interventions, and we've developed sort of several different approaches over the years. Some traditional, I'm a clinical psychologist by training, so we've developed traditional sort of psychotherapy counseling interventions. We actually got funded to create what we would call an app about about 18 years ago, when long before smartphones existed. But for folks that maybe you remember your parents having a Palm Pilot on devices such as those. We weren't very successful in creating efficacious ones, and I chalked that up to being a brand new assistant professor who didn't really understand team science at the time. And now I'm hoping, but with the fact that we're working with so many other smart people, that we'll be able to do a better job of that. We've developed some approaches that use a concept called mindfulness, and then we've actually worked in healthcare systems to do what are called system change interventions that use technology actually at the point of care with the electronic health record. And we've worked with a wide variety of real-world systems, healthcare organizations, a lot with smoking cessation quit lines around the country. We've worked with patient navigators who have broad reach into underserved populations, and we've done a little bit of policy work as well. So that's in general sort of the scope of work that our lab does. Part of the reason we focus on tobacco is it is the leading preventable cause of death and disability in the U.S. We all think that things like alcoholism, drug abuse, suicide, murder, risky sex, automobile accidents are major public health problems. Well, tobacco kills more people than all of those combined every year. So it is a huge, enormous public health problem. It is incredibly prevalent. People, the rates of smoking have declined dramatically in the last 50 years, but we've been having a very slow rate of decline over the last decade or two. And still, 1 out of every 6 U.S. adults is a cigarette smoker, so it's still a highly prevalent disorder. There's good news and bad news. The vast majority of smokers want to quit. Over half of them try to quit every year, but only about 1 in 20 of smokers every year are able to actually successfully quit long term. So it's an incredibly addictive drug and very difficult to get off. There is very, very good news when you think about it, though, from a public health impact, and that is that the American Cancer Society looked at the decline in cancer deaths in the U.S. that we saw over about a 12-year period and attributed about a half to almost 85% of those deaths were that decline was due strictly to tobacco use. It was not due to new surgical techniques. It was not due to new drugs, new technologies, radiotherapies. It was due to just reducing the prevalence of cigarette smoking. So when we are successful at addressing health risk behaviors, we can have an immense population impact. And so that's actually what we're aiming for, and obviously many, many people studying in this or working in this space. So why the social determinants of health, and what are they? They're really sort of the conditions that people live in. And they include the physical conditions, whether you live in poor neighborhoods, wealthy neighborhoods, contaminants are in the environment, et cetera. It includes the economic environment. Are you living in poverty? Do you own a home? Are you living in a shelter? Are you living in a mansion? It includes social factors. Is there a lot of crime in your neighborhood? Is there what's called social capital, meaning that you and your neighbors can come together to accomplish common goals? So we're going to go through a few of those today, because what we know is that these social determinants play a huge role in health, and that there's a profound gradient in health and mortality attributable to social determinants. For example, poverty is incredibly bad for your health. Low financial resources, low material resources is linked to higher rates of virtually every chronic disease known to man when studied in the developing world. So there's social determinants play an enormous role in health, and they're what causes so much inequity in health. And I want to point out that context may play actually an exceptionally large role in really disadvantaged populations. And there's been several sort of reviews and studies recently that have shown, for example, that the impact of genetics is much smaller as socioeconomic status decreases, and the role of environment and context plays a much larger role as SES decreases. And so one analogy that I use to help people get their head around that is thinking about planting two seeds. One is a seed that's been, bred over years to be, yield these huge, beautiful plants. The other is sort of a scraggly, runt of the litter kind of seed. And when you plant them in rich soil with plenty of water, then you see the plant with the good genetics really blossom and bloom relative to the other plant. When you plant them both on rocks with no water, you don't see either plant bloom. And that's really kind of what you see with the social determinants. That's the context plays such a giant role and overshadows genetics when you're really looking at these disadvantaged populations. And I'll give you some examples of that here today as we go forward. So why do these social determinants impact health? And I'm going to particularly today talk a lot about socioeconomic status, which is one of the social determinants. And people have proposed a variety of different mechanisms linking SES to health. And one is, and all the different theories boil down to some common elements. So number one, if you have low SES, you're just exposed to more negative experiences. You're exposed to discrimination, chronic stress, violence. You're worried about paying the bills, keeping the lights on, getting your kid to school safely, your own safety. So you're just exposed to an immense amount of negative environmental influences that are not shared by higher SES populations. Not only do you have more bad things happen to you, you have less access to good things. And we know that folks living in these dangerous, disadvantaged environments have lower levels of social support, and there's lower levels of trust and cohesion in their neighborhoods. So more bad things happen, less access to good things. Guess what? That influences how you think and how you feel. And in fact, there's a lot of evidence showing that living in these really disadvantaged environments can have a profound impact on people's view of the future, their ability to plan for the future, their ability to think, and this is really critical, their ability to think they can actually impact their environment, because they have a lifetime learning history of showing that no matter what they do, they have very little impact on their world. Where most of us that are highly educated, we live in, we generally have all the material resources we need. We think if we can actually change our paths in life based on our efforts. So really profound, really horrifically bad, frankly, from a human flourishing perspective, influences on people's affect and cognition. And when that happens, then you see much higher levels of health risk behaviors. So because of the fact there's why plan for the future if you don't think that you're going to actually make it. So these common mechanisms, and we've started to look and try to map out which of these sort of link SES to health. And so in one of our first studies I'm going to talk about is we have the great thing about working in Houston is we live in the most diverse city in America. And so we can do studies where we're evenly split, for example, among major population groups. And in this study, between African Americans, Latinos, and whites. And I'm going to show you 4 indicators of socioeconomic status. And let me walk you through the slide, or the first graph, because I'm going to show this form of a graph over and over and over today. On the horizontal axis is simply time, and it's usually referenced in time to a quit date. So these are all people attempting to quit smoking. And so the horizontal axis shows a time point of 4 weeks after that quit date and 26 weeks after the quit date. The vertical axis shows the people that successfully quit, the proportion of people that successfully quit. In these 4 graphs on this slide, the red group is always the advantaged group, and the blue line is always the disadvantaged group. So here you can see that folks that make more than $20,000 a year, total household income, are much more likely to successfully quit smoking than folks whose total household income is less than $20,000. So why is that? Because in this study and in all of our studies, everybody gets exactly the same treatment. They all get counseling and pharmacotherapy provided by the study. So it's not an access to care. It's not an access to treatment, because that's where everybody goes as being the reason why low SES people don't do as well. And that's actually, in this case, we've controlled for that because everybody gets basically about the best treatment available. And yet you still see these profound differences by income. You also see them when you look at educational level and insurance, whether they're insured or not insured, and employed, whether they're employed or unemployed. And in every case, the more advantaged group has much higher cessation rates than the disadvantaged group. So there's something going on here, and I'm using this one study, but we see this effect in every single one of our smoking cessation studies, where socioeconomic status and indicators of it play a really profound role in predicting outcomes. So again, back to why is that? And so what we've done is use a technique called structural equation modeling, which is simply a series of simultaneous regression equations to model links between various constructs. And so here is one of the first models we've done from about 5 years ago, showing the pathways that link socioeconomic status to relapse. And basically all the circles are latent variables. All the little lines coming off the latent variables show indicators of that latent variable. Those are the actual measured variables. Not important really to be able to go through all those. The point is that in this, every single pathway in this model is significant. The model fits quite well. We've done what's called multiple groups analysis, which is the ability to compare across different groups in your sample. And in this case, we've done it across race and ethnicity. And we find that this model holds whether you're looking at African Americans, Latinos, or whites. And it's a pretty robust model. And just to walk you through, one pathway of how it works. So if you look, starting at the left, and we measure some variables at baseline, we're predicting longitudinally. Some are measured at the quit date, and then relapse is measured at week 4 after the quit date. You'll see that socioeconomic status, as socioeconomic status declines, neighborhood disadvantage also increases. So lower SES, greater neighborhood disadvantage, less social support, greater stress, less agency, more likely to relapse. And I know I went through that very fast, and it's not really critical that you follow through all these different pathways. But the point is that these pathways are mapping out exactly as the conceptual models predict that they should, showing that in all these cases, low socioeconomic status has these bad effects on outcomes, and they're mediated through these specific hypothesized mechanisms. So, but that's only one study. So we've actually looked at whether we can replicate this model in other populations. And in this case, we did it in a sample of pregnant women, again, split a third, African-American, Latino, and white, and what predicting postpartum relapse. So this is among women who actually quit smoking during their pregnancy. We didn't have all the same variables as we did in the others, but we replicated with the variables we had, we replicated again the key pathways where low SES leads to greater stress, less agency, more likely to relapse postpartum. So again, showing that there were, these are some important mechanisms linking SES to outcomes. We've done it also for SES and multiple cancer risk behaviors among African Americans, again, replicating the key pathways. I'm not going to spend much time on this, just give you a brief the brief view of the graph to let you know that these things are playing out exactly as hypothesized. So, sorry, I needed a little drink there. We work with really, really underserved populations. We, for example, with Latino immigrant populations that speak only Spanish. And there are issues that arise in working with specific vulnerable populations that can make measuring traditional socioeconomic indicators difficult, or else change the meaning of those indicators. And so in these different kinds of populations, sometimes the variable doesn't mean the same thing because of the cultural factors that exist. And I'm just I'll use Latino immigrants that we've studied as an example. So Latino immigrants, it's been actually a number of people have looked at traditional SES indicators and not found that they're very good predictors of outcome. But there could be some reasons for that. And that is because, so for example, in a Latino immigrant, their education level is often completed in a country different than the US. And so the meaning of a high school degree from Mexico may be very different than the meaning from a high school degree in the US, and same for college, et cetera. In addition, Latino sort of cultural values, typically the family size is larger. So there's more people living in the household, which makes using income a little more difficult because you can't just divide income by the number of people in the household. There are certain fixed costs that go with, living, rent, et cetera. And it doesn't map on to a simple, income per person. In addition, Latino families who are immigrant often send large portions of their income to their family members back home. And so, again, that influences how well income might predict. So traditional indicators often don't predict as well in some of these alternative kinds of populations. But there are ways to think about this in a different way. And one of the things that has been used is called subjective social status, which is just asking people where they stand in the social hierarchy of America. And it's done by simply giving them a 10-rung ladder, and they're asked to indicate on what rung of the ladder they are, with the top of the ladder representing, the people who have Bill Gates, the people that are really best education, most money, most well off. The bottom of the ladder being, people living in poverty, unemployed, et cetera. And so people simply indicate on the ladder where they believe they stand. And it's been a very interesting construct used in a wide variety of studies, and I'm going to show you what it does in ours, and particularly, whether it helps us in understanding SES in different kinds of populations. Another way is to look at financial strain, because that may be simply asking people, do you have enough money to pay your rent, to pay your bills, et cetera? can help us get around some of the issues related to different sized families in different population groups, to sending money back to families in other parts of the country or the world. And so this is another way of thinking about it, getting an indicator of socioeconomic status that might be a little different than a traditional indicator. So we wanted to see whether they predicted, and we looked in that same population, actually, that I mentioned earlier, the one that's a third African American, a third Latino, a third white, using the same formatted graph that we use over and over. And I'll just tell you that things map on to predicting abstinence exactly as you would expect. The blue line are the folks that have the highest level of subjective social status. The green have the second highest, the tan the third, and that purple line have the lowest level. So you can see that simply the higher level that you indicate self-report you are in the social hierarchy of America, the more likely you are to quit. And this is after controlling for the objective indicators of SES: education, income, insurance status, employment, etc. So this is really adding something incremental and unique over and above traditional indicators. So does it work in the Latino population, immigrant populations, which one of the things we're really interested in? And by and large, it performs exactly the same. The purple line has the highest level in the social hierarchy, green the second highest, red the third highest, blue the bottom. And I should say that the traditional indicators do not predict in this population, but subjective social status does. So it actually is, we find this incredibly useful because it helps us sort of dispute, at least in our mind, the belief that socioeconomic status doesn't matter in certain immigrant populations. We think it matters tremendously. We think our indicators that we traditionally use for it simply don't work as well in that population. So real interesting there. Next thing is financial strain. Again, in our third, we see that financial strain predicts exactly as you would expect. And in fact, you'll notice that the proportion of people who quit in the highest level of financial strain is 0. None of the highest quartile of financial strain folks were able to quit versus 13% in the lowest financial strain. So again, this is after controlling for all the traditional indicators. How about in the Latino immigrant population? And here we see a slightly different pattern, but generally consistent in that the three groups with the lower levels of financial strain kind of are all fairly close together, but the purple line is the group with the highest level of financial strain, and they have a significantly lower abstinence rate than the other groups. So not quite as beautiful and clean as we've been seeing, but again, showing that some of these alternative indicators indicate that socioeconomic position is important in this Latino immigrant population, and we just may not have been measuring it very well with traditional indicators. So now let's dive into, so now I've just sort of hopefully convinced you that socioeconomic status is a big deal, that it predicts always in every population we ever study, and that's never an access issue because everybody's always got treatment, and so that's just not it. So what about neighborhood disadvantage? Because this is sort of the macro context level. And you can think of, so let me kind of give you how we think of it. We think of your neighborhood. You can think about your neighborhood in terms of socioeconomics. What's the rate of poverty and unemployment in your neighborhood? What's the ethnic makeup? How many people own homes? And there are profound differences, obviously, in that. You know, Rice University is set right between one of the wealthiest neighborhoods in the city of Houston and one of the poorest historic African-American neighborhoods in Houston. And they differ profoundly on socioeconomics, and they differ profoundly on social factors. The wealthy neighborhood, much fewer problems, much less crime, People feel like they share the same values as their neighbors, etc. So these social factors differ dramatically across neighborhoods. And then, of course, there's the physical environment. And if you think about where you live and you think about a wealthy neighborhood and a poor neighborhood, in the wealthy neighborhood next to Rice, there are no mom and pop stores. There are flagship grocery stores with, beautiful Whole Foodsy kinds of places. There are beautiful sidewalks, parks, green space, lighting, etc. In the poor neighborhood, there are no grocery stores. They don't go in there. It's only mom and pop convenience stores that are on every block. They're small. They don't have good food. Streetlights are broken. Sidewalks are non-existent or broken up. And they're just completely different environments. So do they have an impact on people's ability to change their behavior? So we looked at each one of those, socioeconomic, social factors, and built environment relative to the ability to quit. And we looked at the first in African Americans, and we looked at Darla Kinzer was a former postdoc of mine, and she looked at unemployment because there's some real theories about sort of the meaning and purpose of unemployment. And she looked at first at individual level unemployment. She finds that just as in all the other graphs I've shown you, the employed group is much more likely to quit than the unemployed group. So that's the individual level. The next thing she did was look at each of the neighborhoods that these people lived in. And she broke those neighborhoods up into quartiles based on the proportion of people unemployed in the neighborhoods. And then she simply mapped out those, the neighborhood level unemployment on our same old graph format that we used before. And lo and behold, it maps on exactly as you'd hypothesize. The lowest level of unemployment have the highest abstinence rates, the second lowest, the second highest abstinence rates, and then the third and the fourth. So the highest level of unemployment have the worst likelihood of successfully quitting smoking. This holds after controlling for the individual level unemployment and other individual level indicators of socioeconomic status. So these are actually pretty darn big effects for context, and actually much higher than you see with things like many genetic patterns that are hypothesized to influence cessation. So just showing again that context, neighborhood level context, not whether you're unemployed or not, but whether there's a lot of unemployed people in your neighborhood, makes a difference when you're trying to quit. And indeed it does. And you see now the same thing when you move to social factors. And social cohesion has been described as sort of sharing the same values as your neighbors, trusting them. Could you borrow a cup of sugar from them if you needed to? And what you see is exactly like what we've seen in all the other graphs. The more social cohesion in a neighborhood, the more likely the individual is to quit. The less social cohesion, the less likely the individual is to quit. So again, showing that these macro neighborhood levels of both socioeconomic, subjective socioeconomics, and subjective social factors predict outcome. And then the last thing is the physical environment. And I've shown you here a window of a really typical convenience store in a poor neighborhood. And I want you to notice there's really only three things that are advertised. And let me see if I can do the pointer here. So there's cigarettes, there's little cigars, there's e-cigarettes, so tobacco, a bunch of different tobacco products are advertised, booze, and gambling. That's all that's advertised in the window of these convenience stores. And in many of these, you can't even see through the window because there's so much advertising. That's a profoundly different environment for a smoker than in a wealthy neighborhood where there is a flagship grocery store and they sell tobacco products, but they're locked up and hard to find. For what we know about cue reactivity in addicts is that your brain lights up when you see stimuli related to your drug of choice. So people who live in these neighborhoods theoretically are having their brains light up all the time. So does it actually, when they see all these stimuli. We don't know that, of course, because we don't have them wired to a EEG as they're walking around. But if you follow that line of reasoning, it should mean, though, that folks living in these neighborhoods with a lot of tobacco outlets should influence their ability to quit. So the first thing we did was just look at how close they lived to a tobacco outlet to see if it would predict outcome. And we controlled for all the usual indicators and socioeconomic status and dependence. And lo and behold, we found that simply living close to a tobacco outlet predicted a reduced likelihood of abstinence. So simply how close you live, and it totally makes sense from what we know about cue reactivity literature and smoking. The next thing we did was to try to get a little more creative and to map on real-time measures of craving and proximity to a tobacco outlet. So in this case, every time we did an ecological momentary assessment, we measured their level of craving and we mapped relative to that level of craving how close they were to a tobacco outlet. And what we found was that their level of craving in the moment was associated with their proximity to a tobacco outlet, but only when they're in their own neighborhood, where theoretically they probably have some kind of a mental map of where tobacco outlets are and where they can get cigarettes. And I don't think this is anything that's happening consciously. They're not thinking, oh, there's a tobacco outlet a quarter of a mile away versus a half mile away. It's simply that people are incredibly in tune to context, and context has these influences that are not necessarily conscious, rational processing, which has been pretty much debunked that humans do much of that. So again, hopefully showing that the built environment can have these influences on the ability to change your behavior in ways that you might not anticipate or that people actually think are a little weird. I had a Nobel Prize winner here in Texas tell me he thought my research was crazy when I was telling him some of this stuff. So it might be, but it's there. So it's pretty interesting. The other thing we've done is look at what we call microcontext, which is simply what's going on in your immediate environment in the moment. And by context, we mean both the individual level context, but the social context as well. So it can be, are there other people in the environment smoking? Is alcohol? Are people using alcohol? Are you in a tobacco outlet, et cetera? So the way we do this is using this. You'll all recognize this from MD2K. We use a variety because this is basically the AutoSense suite. But EMA is simply referring to measuring something in real time in the real world. And people think of it as self-report, like down in the bottom right corner with the smartphone, but it's really any kind of measurement, whether it's physiological or not. And the great thing about that is when when talking about self-report, it dramatically reduces recall bias and error. You obviously are doing it in real time in the real world now, and the more intrusively you can do it, the better, because the real world is nothing like the lab. And because so many of the really important influences on behavior change really dramatically, it starts to give us an insight into the dynamic relations among key determinants of behavior in ways that we've not been able to do prior to being able to do more sophisticated EMAs. So most of you are probably familiar with how that works, being part of MD2K. And so what we did was simply look at our self-reported EMAs. And we know there are 3 triggers that are very powerful for smokers. And several of those triggers are much more common in low socioeconomic status environments. And so we just looked at every EMA and we classified it as to the presence or absence of that trigger. And then we looked at the combinations. So there were 3 triggers. One was negative emotion. We know that people are much more likely to lapse when they're experiencing negative emotions. And we looked at whether the individual was drinking or not, because people are also more likely to lapse when they are in consuming alcohol. Rumor has it people make some bad decisions sometimes when they're using alcohol. And then finally, we looked at whether they reported other smokers in the environment. And then we just looked at whether there were every situation, whether 0 triggers in that situation, was one of the triggers present, some combination of 2, or all 3. And what we did here was map it out. And you can see there's no trigger in the environment. And it's simply the likelihood that that situation results in a lapse. So in 0.4% of the situations where there's no trigger, that results in a lapse. Versus if there's one trigger present, anywhere from about 0.6 or almost to 3% of the situations result in a lapse. You look at 2 triggers and you're going from about 3 to 8 now, and all 3 triggers, it's about 18% of those situations are resulting in a lapse. So this is a really powerful contextual effect. 1 out of every 250 of the situations where there's no trigger results in a lapse, versus almost 1 in 5 when all 3 triggers are present. And you'll also notice that it looks like other people smoking, this purely environmental factor, tends to be one of the most powerful predictors, either alone or in combination. So that really other people around makes total sense in a million different ways. So really, again, huge, powerful effects of context on lapse. So the other thing what we can do with EMA is, we have all these multiple repeated measures of constructs. And so, here's 2 example patients. And let's just pretend we're talking about negative emotion. And you can see that patient 1, the red line, their negative emotion is relatively flat. They don't bounce around very much. They don't seem to show an increase over time. And compared to patient 2, their mean level is much lower, etc. Versus patient 2, the blue line, you can see that their mean level would be much higher than the red line, than patient 1. There's a bit of an upward slope in negative emotion over time, and they're much more volatile, meaning they're bouncing around a whole lot more than patient 1. So what we've done then is look at these trajectories and look at the means, the slopes, the volatility to see how that maps on to lapsing and craving. And what we find is that these trajectory parameters predict relapse. And some of the really key ones for us that seem consistent are craving, negative affect, stress, and happiness. So the higher levels and the greater positive slopes, meaning they're increasing over time, of urge, negative affect, and stress, the more likely the person is to relapse. And happiness actually protects people. So having a higher level of happiness tends to help them not lapse. If they're increasing happiness over time, that helps them not lapse. In general, the mean and slope are relatively correlated at a low level and seem to be providing unique incremental information. So again, we've never had this ability to do this kind of thing until EMA. Now, other people have been doing this for a long time now, but until we started getting into this real world stuff. And now the great thing with programs like, AutoSense is that we can actually be measuring stress unobtrusively, real time, in the real world, no participant volition required, the same for smoking. So now we're able to do this in a much, much more fine-grained way than we ever were with the self-reported EMA. So overall, inequities, our focus is all about reducing inequities. Inequities impose a huge public health burden, and there's a profound gradient by socioeconomic status. And to illustrate the impact that tobacco plays on that, there was a study that looked at the proportion of the social gradient accounted for by tobacco use in 4 English-speaking countries around the world, the US, Canada, England, and Australia. And they found that in all of those, about 50 to 60% of the social gradient in mortality is attributable to inequities in tobacco use. That meaning simply, if we could reduce inequities in tobacco use, we could more than halve the social gradient in outcomes. Pretty profound. You'll remember at the very beginning of of this, I noted that we've had some really powerful public health success in reducing tobacco use. We've reduced actually the prevalence of tobacco use from about 50% in men in the early 60s and down to 18% now, a general decline across the whole population as well. And that's had profound public health impact in a positive way. But what we've not done is make special efforts to reach disadvantaged populations. So as we've done that, we've actually increased health inequities related to tobacco. And that's because we didn't reach out to low socioeconomic status populations. We didn't reach out to populations that have psychiatric comorbidities. And what's happened now then is as we've reduced the prevalence of tobacco use everywhere else, we've had much less of an impact among people living in poverty. We've had much less of an impact among people with psychiatric comorbidities. So we've essentially concentrated tobacco use very heavily in very vulnerable populations. And so as we move forward, we have to have a huge effort. And I hope all of you technologists think about this as going forward, is how can we better use technology to reach these really vulnerable populations and help them? Because we have to do that, or else we're going to actually even further contribute to inequities if the only people that benefit from our new technological advances are those people that have the means and the resources to have access to them. And then, my always mantra, context is huge. Don't forget about that. Genomics, genetics are not going to solve our world problems. We've got to pay attention to our world around us, the context that we live in. And then I like to, a lot of times, maybe just take a minute to say why understanding these kinds of things and building conceptual models is important. And so I've got a very simplistic kind of schematic here that lists, some of the broad categories of determinants that influence health behavior. Obviously genetics, demographics we've talked about a lot today, but there's biological and psychological predispositions. Context we've talked a lot about today. And we've actually talked about acute precipitants, meaning those momentary factors that are most proximal to the actual behavior. All of those have an impact, and they all tell us something important about intervening. So for example, as we learn about acute precipitants, they can help us think about how to design our just-in-time adaptive applications. They can help us think about whether rescue medications might be useful, or whether interventions that are triggered by sensors actually can have an impact, and whether we can use some of the sensor data to really help drive what we do in the moment. So probably most of you kind of get that. Some of you are probably actually working on those problems right now. Genetics and predispositions are important because people respond differently to both behavioral interventions and to drugs based on their genetics, based on their sort of personality characteristics. Context is huge. I pointed out, for example, that having a close proximity to a tobacco outlet, it predicts lapse, it predicts craving. We could do something about that. We could zone so that, for example, you couldn't have tobacco outlets in residential neighborhoods. We do that all over the country right now with respect to sexually oriented businesses. We don't allow them in residential neighborhoods. We also typically have zoning laws around tobacco use, but usually just around schools. So you can't have a tobacco outlet around a school for 500 feet. So there's things we can take from these kind of models to help us think about how can we better, we saw that social cohesion predicts, so how can we better engage communities to get them to pull together to address health risk problems? If we can reduce crime, simple things like that, smoke-free legislation, greater access to care, all contextual kinds of things that we could influence to improve health risk behavior. And then finally, if you really want to tackle social determinants at the root, we need to reduce inequities. And there's lots of good evidence, for example, around early education programs and other kinds of programs that reduce income equity, inequity, et cetera. So that's why we study these kinds of models, because they help us think about better ways to improve our interventions and our policies going forward to improve health. So again, I mentioned at the beginning, we do the 3 T's: translational, transdisciplinary, team science. We work with a huge variety of people from all over the country, and including obviously many of the MD2K lead investigators. So with that, I am happy to answer any questions.
It's a very nice presentation with many questions that I have, mostly looking forward. So I would ask 2 for now, and and allow others to make use of the time if they like. The first one, you presented data about one trigger, presence of 1 trigger versus 2 triggers versus 3 triggers.
Yes.
It was very interesting. But when these 2 triggers or 3 triggers are occurring, what do you think is going on? Is one trigger going? How are they interacting with each other to produce the combined effect? Is a presence of alcohol inducing the craving that gives rise to a stress, and which might get accentuated by seeing others smoking? So if you could say something about how you think that they are interacting with each other to ultimately produce the effect, it'll be very helpful.
Sure. Well, one, as you know, we don't have that fine-grained data to empirically test that yet, because we've got self-report at one point in time, and then we don't have another self-report, obviously, in most of the cases for an hour. You know what I mean? So we don't, unfortunately, have the fine-grained. We've done some what we call lagged analyses. So, for example, where we show that when people experience negative affect at one of the EMAs, it increases their expectations about the ability of smoking to reduce that negative affect, and that leads to greater craving, not only in that moment, but in the following moment. But it's not a very fine-grained, because the assessments are, actually, hours apart generally. So we don't, unfortunately, have the fine-grained enough data to really test that. With some of the things we'll be able to infer from AutoSense, we'll have a much better job, because we'll have stress minute by minute. We'll potentially, with your new work around a craving model, you could potentially be looking at this kind of, at least predicted craving level. But right now, but frankly, I think they're all reciprocal. So, and actually, most of our social cognitive models that we've had for the last 30 years would also suggest that they're reciprocal, meaning that it's that you see someone smoking a cigarette, it raises your craving, that stresses you out because you're trying to quit, blah, 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 and it's this reciprocal negative cycle. Conversely, your boss yells at you, that causes you to crave a cigarette and puts you again in that same kind of reciprocal. So it's a great question. I don't know the answer. We've modeled lagged, and we find that expectancies, meaning cognitions about the ability of smoking to take away that aversive condition, actually seem to be mediators. But it's a very, even with the EMA, I still consider that a very crude kind of approach.
Okay, I think that certainly is helpful, and makes us, again, even more eager to look at the data when we get it.
Yeah.
So the second question is from a precision medicine point of view. So many of these analyses, they are done across populations. So pooling together data from many people, where each of them contributes one endpoint as it relates to the labs,
right?
The relabs. So, but now if we think from an individual point of view, the interventions are all to be delivered to one individual at a time, meaning for each individual, could be an entity or target. And when we think about them as the target rather than what happens to the population, then many of these events, they don't repeat, meaning the lapse certainly first lapse happens only once. And so many of these cues or triggers, they might happen one time, and one individual may not react to it or may be tolerant to it. Another individual may be less tolerant to it this time around, but next time around may be more tolerant to it. So there is so much variability in between these occurrences across people and across time for the same people. So if we think about development of these interventions or finding the right triggers from an individual point of view, how should one think about it? Is there a new analysis that should be pursued, or is there different ways of looking at the data that should be undertaken, or can we reuse several of the similar techniques that we have thus far used for data analysis?
Well, if I'm laughing because it's like, holy crap, I know. And that's actually why I'm so excited to be collaborating with all the MD2K investigators and other folks, because it's gonna be really, really tricky knowing. So, for example, like you said, if you think about an individual, so that's one of the things we're sort of excited about, heart rate variability. And so for those of you that don't know, heart rate variability is just how much actually your heart rate is able to fluctuate. And it's kind of backwards to what people often think. The more heart rate variability you have, the better. And heart rate variability is thought to be a direct indicator of self-regulatory capacity. And so self-regulatory capacity, I kind of think of as being maybe a way to capture a lot of different influences that might be hard to model sequentially and simultaneously. So it captures the fact that one person has low heart rate variability because they had one giant stressor earlier in the day, versus I have low heart rate variability because I've had a series of small insults across the entire day. But I don't know. I mean, that's actually, why we've got, Jim Ray doing machine learning with us. That's why we've put in that system science grant to try to do some of the dynamic fluid models, because I don't know the right answer for the analytic approach. But there may be some sort of, I keep thinking, I know you've kind of been doing that a little bit with the stress being perhaps a core indicator. And I'm thinking heart rate variability actually might be something that we can really leverage in terms of capturing a lot of that. And so when heart rate variability is low, then you know that it's probably good to intervene, and particularly if any other kind of trigger hits, even if it's a relatively low severity, versus, you know what I mean? That there may be some ways to generalize, and actually the dynamic systems fluid model grant that we've been trying to get, Daniel Rivera shows that there is a fair amount of generalizability with the models he's used. So it may be that doing some of that kind of modeling helps us tackle some of those problems. But good Lord, you know me, I'm a statistical idiot. I lost everybody on that answer. It's pretty dead quiet out there.
Thank you, Dave. I should give a chance to others. So I talked sufficiently.